dentistry and health. Go ahead, Dr. Stanley.
Okay, well, we just gave an intro. I'll give a short intro. My name's Logan Stanley. We're dentists in Marble Falls, and I practice with my dad. And as I had just explained, that was pretty critical in how I began practicing the way we do and the philosophy that the approach that we take to dentistry. It's a shift that he made, and it's a shift that I chose, and it's a type of dentistry we believe in, and it's very important in my opinion, in our opinions, that you have to look at the whole. You cannot break out a body part and treat it without considering the whole person. So when you're talking about overall wellness, you've got to consider all the parts, and the mouth is a big part of that, and it can be a big part of problems and sources of problems in a lot of patients. And so I'm going to switch over here. I'm going to try this share screen, and I'll hear y'all. Y'all can tell me if it works. Can you see my screen?
Not yet.
Okay. How about now?
Yep, there you go.
Okay, and then should be full screen now, is it?
Yes.
Okay. This is a presentation we've given before. Oftentimes my dad and I will give it together. We've worked with a lot of physicians, integrative-minded practitioners, and so we've been asked a few times, because this is familiar to some and it's very unfamiliar to other people. And so most of what's in here should be a pretty good overview of what we look at. Obviously, we cut out pieces, and I might breeze over certain pieces. And so that's what this was put together for, and it's intended to be informational. I know oftentimes, if y'all are anything like me, you'll hear these profound presentations, and you look to the person sitting next to you and go, "Oh boy, I'm in real trouble." And so that's not really what this is intended. It's intended to be informational. I'm of the opinion that if a patient gathers as much information, applies it to their personal circumstance, they're going to make a good decision. And how it applies to them. You surround yourself with people that you trust and confide in. You do your own research. It's a mandate of ours now in our own healthcare, is to take ownership of it, and you're in control of it. And so from a standpoint of giving a patient that information, helping them work through and understand some of those things, and then it's a decision that they need to make for themselves. But knowing is a critical first step. And so hopefully y'all will find this informational, and it'll help you make those decisions. Real quick overview. I guess what you would call us is biological dentists, integrative dentists, health center dentistry. Basically, those are a lot of words that say that we consider the whole person, the body that's attached to those teeth. Not often teeth walk through our door. There's usually people attached to those teeth. And so we have to treat with the person in mind. We can't just ignore the rest of the body and only treat the mouth. We are dentists, molar mechanics. That's what we're taught to be. We're taught to fix teeth. We're taught to get people out of pain. We're taught to put materials in that last a long time. But rarely are we ever given the big picture that some of these things that we do can affect people on a lot of levels, systemic levels. And vice versa, a lot of these systemic issues can absolutely have impacts in the mouth. And so as a, quote, biological dentist, that's not a recognized specialty. I would say that it is some degree of a specialty. You've got to commit to it, and it changes the way that we look at every scenario and every procedure and every patient that comes through our door. And it's treating with the intention to have minimal impact on health, meaning we use materials that are compatible, that are inert. And for patients that have issues that we can stem back and relate back to some of the dental toxicity, then you're looking for a maximum impact of removing some of these materials, addressing some of these. And typically this is done with the aid of physicians and other practitioners. We use blood work and toxicity. There's multiple tests we can use and look at blood work. So it's not just a shot in the dark. This is typically a very calculated approach when we do have this discussion with people. So I have an analogy that I give a lot, and I think it's a pretty good one. typically an approach to just generalized, integrative, kind of holistic care, if you will. Holistic being a buzzword now, but it just means the whole. You treat the whole. You may have to focus in on a part, but just like with any other ecology or in nature, it's like the water balloon. You push one side and something pushes out the other side. So you have to consider that. If I put a patient, if I jumped in a swimming pool with a backpack on my back, the younger you are, the more capacity you have, you start piling rocks in that backpack, and most people can swim. They can keep their head above water, and you can tote around a certain amount of rocks. But the problem is when you start getting too much weight, too many rocks, too many things that are weighing you down, you start sinking. And that's often when we do fall into immune dysfunction, immune problems, autoimmune issues, these chronic debilitating problems. And I think the approach then is start identifying some of those rocks and trying to get some of them out and get your head back above water. Some rocks you can't get out. Once they're in there, they're in there. Other rocks you can get out. And unfortunately, dentistry is a big rock that can be removed in a lot of patients. And so that's kind of an overview of how we look at the work that we do. There's some things on here some may be very familiar with. I'm sure a lot have heard about the mercury issue and the silver fillings, the mercury fillings. It's controversial. It's been controversial since 1850. And so it's been around for a while. I'll touch on some of that. Nickel restoration, materials, more or less incompatibility, other materials, and how that can impact a person's health. Root canals, endodontically treated teeth, that's a little more controversial. Most of this that I'll talk about today is not really the accepted norm. Bits and pieces are. Some of the established kind of approaches and thoughts on this have been like they've been for 100 years. So some of this is, I don't think controversial is a good word, just thought-provoking, I guess, especially for dentists that are trained and steeped in these things. Jawbone osteonecrosis, cavitations, I'll touch on that. It may not be as applicable, but it is something that we do look at and have to pay attention to. The oral microbiome, just the ecology of the mouth and how delicate that is and how important it is to balance it and get it back into balance. And if not, then you see implications just like you would anywhere else up and down the GI tract. Orthocraniofacial considerations, I don't even have really a slide for that. I'll touch on that. And then some other treatment modalities that we use that some may be familiar with. And there's also some topics that I don't even have a slide about that I'll touch on as well. And then a bit about our protective protocol. If we work this hard and patients pursue this topic and acknowledge that there's materials and toxicity in their body, and it takes effort to address it, it would stand to reason that we have to be very, very careful and calculated when we do address patients and address some of these materials. So I'll touch on some of the protective protocol as well. Real quick, Mercury Facts. Most are familiar. In fact, I don't think anybody on this planet would dispute that mercury's toxic. It's not good. WHO, United Nations Environmental Program, worldwide agency, quote, no safe level of mercury, one of the top 10 chemicals of major public concerns. Very serious health concerns in very small amounts. I believe it's been said that it's one of the most, if not the most toxic non-nuclear substance that comes out of the earth elementally. And so it can be bad news. It's toxic, dangerous in small amounts, especially in long-term chronic exposure. It's got a ton of negative side effects, enzymatic activity, detox and methylation pathways. I don't know if Aline, if somebody had said they gave a presentation, Kim, on the methylation pathways. And basically, they're just a bazillion little on and off switches that are happening without us thinking about it. And it regulates anywhere from stress response to brain activity to energy production to detoxification pathways. And mercury can really throw a wrench in a lot of that. And so just another reason that it's a concern. Many other systems, neurological, cardiovascular, renal, on and on. It's carcinogen, immunosuppressive. It's damaging to genes. It's a big inducer of oxidative stress. directly and indirectly. Interestingly enough, Boyd Haley is a researcher that we've heard lecture quite a bit, and he talks a lot about mercury toxicity and studies it, but talks a lot about iron toxicity as well, and how mercury toxicity can lead to the displacement of certain iron molecules in the electron transport chain, and how the iron itself can be a huge inducer of oxidative stress. And synergistic toxicity with other metals, and this is something that's been studied and I think pretty well understood. Mercury is bad, lead is bad, nickel is bad, cadmium. I mean, you've got all these elements that by themselves are toxic, but you start putting them together and you get 1 + 1 = 10, and sometimes 1 + 1 = 100. And so a lot of the studies on mercury have been done in the lab with just elemental mercury, or maybe organic mercury, or the forms that it can take. But not often is it done in a living system. It is, we can look at it, but the synergistic toxicity is something to be considered. The fillings that most have, they've been used for 150 years, about 50 to 55% mercury. They've got some other trace silver, tin, copper in there. It's technically not an amalgam. It's technically not an alloy. It's a solid emulsion, which means that mercury can be recovered. It's unreacted. It literally, if you blow it up on a huge microscopic cell, you still see elemental liquid mercury in these fillings. They do continuously leak vapor for the life of the filling. Granted, in very, very small amounts is right, but when you have a mouthful and it's exposed over a lifetime, it may be a concern. Some can tolerate it. Some people have fantastic genetics. They've got things going their way, and their body can get rid of it. I've got a practice full of patients. I won't say full of patients, but there's some that have had these things, have had some of these other things I'll talk about, and they're clinically okay. They don't have a lot of these problems. It doesn't mean that that's okay, and it doesn't justify the use, but we're dealing with humans, and everybody's different. Everybody's got their own thresholds and capacities. So again, I'm talking about just standards, and a majority of people. You see down there, 67 million Americans, this is a study done, and I've got these things cited down below, exceed what our own EPA has deemed safe level of intake. There's a lot of discrepancies between agencies and state and federal and agencies that as to what's safe, what isn't. It's really hard to get an idea. So you kind of just take an average of these things. But again, you step back and look at the big picture and say, mercury's bad, we know it. Why are we still allowing in the US these things to go in? I would certainly be in favor of just banning it. Some countries already have. And so I think at some point it may go away, probably hopefully sooner than later. Couple of French dentists, my understanding, brought it over in the mid-1800s. It was the only thing they had. That was back in the day when they were swallowing it and rubbing it on wounds, but it was still controversial to put it in people's mouth. It actually caused the first breakup of the American Dental, the American Federation of Dentists, and it was so controversial it broke into two. The faction that was in favor of banning it went away. The faction now known as the American Dental Association has since promoted its use. So it's got some history with it too. Pictures. I took some pictures out because some of them just weren't real pleasant to look at. Most know, I mean, they've seen in their own mouths or seen in others. You know, they're pretty unsightly aesthetically. They're not the greatest things to look at. This is I'm going to come back to this picture, but I'll talk on oral galvanism. Basically, you put a bunch of metals in the mouth and submerge them in an electrolyte, and you will start getting electrical activity, which can promote the dissolution and the breakdown of these materials, on top of set up a lot of these energetic interferences, if you will. So you put a bunch of metals together, and you'll see that happen. Over here, you see this is a root canal that actually has mercury in the tip of it, buried in the bone, and I just don't think that's a good idea in anybody's book. But we do see that. I want to go back here. Sorry. There's a video. I'm going to try to link this. This is called the smoking tooth video. This has been around for about 20 years, and it's on YouTube. Granted, everything on YouTube is true, but they take a. Actually, let me back out of that. That's not the one I want to show. It's this one. they take a tooth that's been out of somebody's mouth for about 20 years and presumably it's a 15-year-old filling, put it in front of a phosphorescent screen, put a black light on it so it bounces off the mercury vapor, and you see that vapor. You see him exaggerating it with an eraser. It's heated up. We drink coffee, we chew. There's a lot of thermal variation in the mouth. And this gives you an idea on that. This video has been a bit controversial. Some would agree or disagree, but I think it's pretty profound just seeing what we're seeing there. So that's an interesting one to look at. Okay, let me get back here. Oop, hang on a second. Where are we? Let me get back to my presentation here. Here we go. Can you see that? Okay. Nickel, this is another concerning material. There's lots of materials that are concerned. This is probably a second most common. Most crowns, partials, things put in people's mouths from the mid-'80s on up to today. Less so today. Fortunately, a lot are making the shift to ceramics, metal-free. Nickel itself is a carcinogen, allergen. It's a big inducer of contact dermatitis. You can read what's listed there. It too has a lot of synergistic toxicities. It's present in stainless steel, and nickel allergy is the most common cause of contact dermatitis, and I believe that came off Mayo Clinic's website. It can contribute to localized chronic hypersensitivity, inflammation, and you can see systemic levels of inflammatory markers when you're constantly exposed to this material, and that's been shown as well. Most crowns, probably most of the crowns done in that time frame I listed, mentioned, are nickel based. They have white porcelain over the top, but there's a nickel substructure. We used to use gold. Gold's a lot more compatible, but gold got too expensive. It's about 70 to 80% nickel. It does dissipate from the appliances. It can concentrate in the adjacent tissue. It can also be absorbed systemically, and a lot will react to it. A lot know they react to it. Certain people that wear earrings that their ears break out, or certain jewelry. It's the nickel in the stainless steel that you're reacting to. So now we go and we glue these in, cement them in the mouth, which is one of the most absorptive part of the body, in a very wet environment. It's a chronic source. And again, it can contribute to tissue inflammation, which can lead to systemic implications. And I'm just outlining kind of the facts. If we want to talk about what do you do about all this, obviously we can touch on that. But once they're put in, they're in for as long as it serves, or until it breaks down or needs to be replaced. And again, some pictures. This is another picture that really highlights more the galvanic activity, meaning there's an electrical charge that happens when you put a bunch of metal in an electrolyte. And I've got a slide on that later, but you can see how it's dissipating and leaching out whatever, ionic activity is happening, whatever metals and elements. And this is an interesting slide. I've not seen it to this degree in other patients, but this is a patient of ours that we documented that. You can see the irritation around these one single front crown. All the other teeth look great. Presumably this person brushes all their teeth, not just everything but that one, but you can see how red and irritated the tissue is. Braces, that's a big deal in orthodontics. And even though these are ceramic brackets, this is probably picture doesn't really do the issue justice. A lot of kids will react to this as well with the nickel. You can request nickel free. We do some ortho. A lot will honor the request to stay away from nickel. Use a nickel free alternative if your child or you yourself is going in to have orthodontics done. Most should honor that request. And again, another picture here. So this is the slide about root canals. I'll touch on this. Again, it's been a controversy since the 20s. Weston Price, some people may be familiar with his work. He was the first, not long after the root canal was invented, I guess you'd say, or the procedure was proposed. He started saying there's issues, and he did a lot of early studies, which we might look back on now and say, oh wow, those are archaic. But at the time, they were cutting edge. Weston Price was a great researcher, and he's still regarded as one. You do root canals when you have infection, tooth is infected, it's cracked, trauma to the tooth, pulpitis, teeth hurt. And basically, there's pulp tissue, nerve, blood, lymphatic. Each tooth is kind of its own little organ with its own little source of blood and lymph and nervous innervation. And you go in there and you clean it out. And at that point, well, if it was dead before, necrotic, that's one thing. But at that point, it's a dead tooth. And as far as I know, teeth are the only body part that die and we leave in place. I don't think that happens anywhere else. I may be wrong. It is a way to keep a tooth. And I think that's what really drives the procedure is something happens and a patient doesn't want to lose a tooth. If you don't know all the sides of it, of course, it's a great idea. Why would I not want to keep a tooth? So at least knowing some of the concerns about them, and then you make a choice. If you weigh it out and decide if it's for you, you know, it's something you would like to do or not. We don't do root canals, and there are a lot of patients that we have to address this with them. And if you look, my next slide shows each tooth on average has about 2 miles of microscopic tubules. They're about the width of a cell, so about 10 times the width of a bacterial cell. Well, you can clean the main canal out, but it's impossible for the best specialist even to mechanically remove 2 miles of dead cell material. And then you seal it up. You've introduced bacteria, or if the tooth was necrotic, it was already infected before. And now you've closed it up, and then those bacteria have an anaerobic environment to thrive in, and they've got plenty of substrate to live off of, all of that dead necrotic cell debris. And so you end up with a lot of anaerobic bacteria. Some can shift DNA from aerobic to anaerobic. Virus, fungus, there's been a lot we've looked into in DNA testing. There was one study that basically said 100% of root canal teeth, symptomatic or not symptomatic, they may look great on x-ray or not, tested positive for bacterial contamination. A study done by somebody that I know well, actually, he showed that he would take enzymes all by themselves in vitro. Granted, this is all done on a bench top, not in a living person, but you take these enzymes and introduce some of these toxins that we know are produced by some of these bacteria, and you'd get up to 80% inhibition in some of these enzyme activity. And so that is the concern. And they can link these microbes to a lot of other issues. You have a much higher risk of infection, periapical infection, abscess in the tooth, and you get a whole issue of inflammatory cascades. These, again, can be a chronic source of inflammation, of chronic inflammation. It's interesting, there's been studies done on some of these in particular, and how there was one study that basically said it does, and this was done in a dental journal, endodontic journal, that apical periodontitis contributes to a systemic immune response not confined to the localized lesion, potentially leading to increased systemic inflammation. So it goes well beyond the mouth. Not all root canals have abscess, and there are some teeth that don't have root canals that are abscess. So those two things are separate for the most part, but you see a pretty high correlation of endodontically treated teeth that carry chronic abscess around. And so again, in a patient that's operating well and hitting on all cylinders, they can absorb that hit. But you get an immune compromised patient, or a patient that has some underlying problems, and this can really weigh them down and affect them. Just some pictures here. You can see how tortuous and how complex these canal systems are, and that's just the main canal. You blow these up on a microscopic cell and it looks like a box of soda straws, and it's just impossible to clean out and sterilize this tooth. And then you seal it up. The body cannot get inside of there because you've removed its innervation in its blood supply. It can't diffuse immunity through the outside of the tooth. It's got to have blood flow to get nourishment in there, and that's what you've done with the endodontically treated tooth, is remove that. So that is something that we look at and we pay close attention to. An X-ray, most have seen X-rays. This patient has had a lot done. Well, I won't go back, but that just shows some of the things in the infection that we can look at and identify with radiography. Jawbone osteonecrosis cavitations, basically when a tooth's removed, we assume that those areas heal in the jawbone, and what we're finding is they don't always heal in, and that can be another source of bacterial contamination, of inflammation, chronic inflammation. G.B. Black's kind of the godfather. Any dentist would recognize that name. He's the godfather of modern dentistry, and he defined what was called a Nico lesion, neuralgia-inducing cavitational osteonecrosis, basically spots in the bone, intrabony, avascular intrabony lesions, defects. Most are asymptomatic. They're pretty difficult to diagnose, although there's ways we can do it with histories as well as x-rays and things. And it's most common at the site of a tooth that's been removed, sometimes decades prior. Wisdom teeth, most people have had wisdom teeth removed, so that's the most common place that we do look. And again, I won't say possible etiology, it's probable that it's incomplete, improper healing. How does the patient heal? What were the conditions? Was it a traumatic removal? There's a lot of things that factor into the chances that one of these will develop or be identified. Postmortem studies, they've done necropsies, I guess you'd say, and up to 80% of the specimens they worked on had these lesions. They didn't know anything about the history. They just knew that they had teeth. They removed them, and the study showed that 80% of the people had these lesions. DNA testing suggests the presence of many virulent microbes. Just like with root canals, we can do DNA testing, and there's a significant amount of plethora of microbes, viral, fungal, anaerobic bacteria, some of the toxicity that's associated with them, as well as just these being huge sources of chronic inflammation. There's a researcher out of Europe that looked at this inflammatory chemical messenger, rontus, that they know is implicated in a lot of these issues: arthritis, dermatitis, MS, Parkinson's. So these are little chemical messengers that our body uses to communicate and say something's not right, and they send out a message and our body responds. And he's been able to prove that there's just extreme amounts of this chemical messenger in these areas and associated with these sites, these necrotic sites in the jawbone. And then there's other things we can look at too, in general, to look at systemic inflammation. C-reactive, CRP is a general one. It's not real specific, but we have seen and followed and done follow-ups on numbers. I understand you had mentioned Dr. Womack's going to be lecturing next month. We worked with her. She's got a couple of tests that she looks at, and my understanding is when she sees elevated signs of that, and when you rule out other obvious sources, that she'll almost always assume that there's some dental involvement. And LPPLA2 is actually a cardiovascular risk factor. It's a little enzyme that they look at, it's an inflammatory test, I guess you'd say. But there's a clear link between cardiovascular problems. I'm going to get in that in my next slide. Cardiovascular problems in bacterial oral microbes. So these are some 3D. We do a lot of three-dimensional imaging where helps us to diagnose these areas, and you can see what should be good healed bone turn out to just be these little dark spots, and we can see them in cross sections and different ones. I can't see this one. I'm assuming everybody can, so this is part of it is identifying them on X-ray, and there are ways to treat. Sorry for the kind of gross slides, but there's a lot of different opinions on this. One way is to curette the dead material out, curettage, and so you gain access. And we've done DNA testing. You can see what comes out, and we know that these things have a significant amount of bacterial activity. And the idea is to clean out the bad and do what we can to promote regeneration and get these sites to heal in. And they can be pretty large sites. Most are about the size of a wisdom tooth that was removed, or a tooth. And you can see kind of the dark areas here. Those, again, this is years later since teeth were removed. Those should be healed in complete solid jawbone. So, and this is a cross section of a cadaver. Sorry, another gross slide. But you can see this dark spot here. Again, what should be that picked up stain, and what should be a good solid bone is just about the consistency of wet cardboard, and that can be a pretty significant incubator of bacterial activity. Microbiome of the mouth. This is kind of a topic that interests me. The oral cavity is the upper GI tract. It's the upper GI tract. And so there's been a lot of research on a lot of levels going into the biome of the body, but especially the GI tract, and balancing it out. And when that gets out of whack, what problems can stem from that? Well, the mouth's no different. It requires a harmonious relationship between the communities, the community of microbes and the host and the environment. And I think I've seen where we're outnumbered 10 to 1 by bacterial cells to human cells. So we not only do we have these bacterial friends, commensal bacteria that we rely on, we need them. And somebody called a human, read this, they said humans are superorganisms. We've got multiple species all coming together to promote the health of everyone involved. So that's how important the biomes are. All of the skin, eyes, gut, urogenital tract, I mean, basically anything that faces the outside, including the tube that runs through our body, is covered by a layer of bacteria that protects us and that we rely on. And so the mouth's no different. These are very highly organized communities. There's lots of cell-to-cell communication to help to adjust population density. Bacteria are the best antibiotics we have. If they can outcompete and keep certain species at bay, when this gets out of whack, you start seeing dysfunction and problems. And again, we depend on them to do a lot. One of the biggest things we see is when this gets out of balance, it's tipped out of balance, is periodontal disease, periodontitis, basically inflammation of the teeth, gums, tissue in the mouth. And it can be significant. And that's when you see the normally functioning biome begin to become disrupted or interfere. There's interference. And a lot of things can lead to it. It's more than just brushing your teeth, although that is important. Systemic health meds, the pH of the mouth, the wellness of overall wellness of the person who's carrying these bacteria around. Again, genetics play in. How does our body tolerate or respond to the bacteria? The microbiology of periodontal disease, again, you can read some of the bacteria involved that we know of, but the shift, at least in our office, and we try to subscribe to, is it's less about going to war with bacteria, and it's more about optimizing the environment, doing what we can so that we can allow the ecology to correct itself. The old theory, germ theory, that bugs are bad, we got to identify what they cause and kill them, Koch and Pasteur, which there was a lot of good that came out of that. But about the same time, there were people, this is 100 years ago, proposing that we don't need to focus as much on the bacteria. We need to focus on optimizing the terrain. And so that's kind of the approach that we'll take in addressing periodontal disease and periodontal issues. And again, there's multiple links. This is very well documented, even in a lot of the well-revered and acknowledged dental journals, about the links between periodontal issues and the bacteria of the mouth and how these do get systemic. They can lead to cardiovascular disease, diabetes, can be a huge source of systemic inflammation that your body's always having to respond to. And again, pathogenic mechanisms linking infection to unfavorable systemic condition. These bacteria don't just stay in the mouth. This is a slide. We'll actually do a lot of phase contrast microscopy. So we're identifying the bacteria by looking at them. So we'll take a slide and look at them under a phase contrast microscope to identify what's there and to use that to monitor. So to address, to diagnose, and to help a patient understand and subsequently treat. And then we use it as a litmus test. So after therapy, of which most of that takes place outside of the office, meaning home care protocols, shifts in dietary and different systemic things that you can address. And patient will come back 6 months later and the slide will look completely different. So if this is an issue, it's a lot bigger issue than just need to brush your teeth and get them cleaned off every so often. You got to look at the bacteria, and then you've got to address the bacteria in the bigger picture of the ecology, and to balance that out and to begin to see a change. If you just pick and choose one bacteria out of the plethora of hundreds and hundreds, probably your treatment success isn't going to be what you want it to be. And a lot of times you can treat periodontal issues non-surgically. Instead of cutting and scraping and suturing, you try to avoid that if possible. This is another slide that actually shows a parasite. This is a single-celled protozoa, or I'm not sure. We didn't do any testing on this, but patients this is something that we see often in advanced periodontal issues. Oral galvanism and autonomics in general. I've touched on the galvanic activity. Basically, it's the production of electrical currents from dissimilar metals, and especially when you put it inside of a fluid or a liquid that can facilitate the exchange of electrons. So saliva does that, and it occurs in the mouth, especially when there's dissimilar metals with different ionic and different elemental makeups, and especially when they're in direct contact with each other. And we actually have little meters that can read this. I'm not as familiar with some of the bioenergetics. There's a lot of people that pay a lot of attention to it. I acknowledge it. I think it is something that needs to be considered. I'm just not my understanding on that isn't where it needs to be. But you can see where some of these readings we get are just far greater than what our normal, what you normally would see in a reading. And so, so when you talk about interfering electrical fields, you get into the energetics of the body. Most people are familiar with acupuncture. It works for a lot of people. That's why acupuncture works, because you're addressing somebody on an energetic level. And so teeth correspond to a lot of this. And so you've got to pay attention to a lot of that whenever you're addressing some of this, especially the galvanic activity. Autonomics, basically, this is something that I've learned a lot lately. A lot are looking at this now. Body-wide, sympathetic versus parasympathetic. Sympathetic meaning fight, flight, freeze. You can call parasympathetic rest and digest. Think of it more as a balance and less as versus. I shouldn't use the word, that term. It needs to stay balanced. We need both. If a patient's in chronic immune stress, if there's always problems, if there's chronic immune potentiators, if there's things that are always on that patient's immune system, they're always having to respond to toxicity, stress, physical stress, psychological stress, it can tip this balance. And if you stay in a sympathetic mode, if your body's always responding to stress, that's a catabolic mode, and it's not a good mode. Patients will not thrive in that mode. People will not. So the idea is to balance that out. And this goes way beyond dentistry. This goes way beyond medicine. You get into the stress and how that can be a big step forward in patients' lives are to address it on that level. So anyway, the autonomics are something we do pay attention to. We do a lot of body work pre and post treatment to kind of balance that out. If we're having to do work on a patient or surgery, they may not be stressed, but their body is responding to the stress of surgery. And so there's different approaches and very well established approaches and body work and different therapies that can be done to kind of balance that out, where a patient can be in a anabolic mode, repose, and you will heal better in that mode and thrive. And again, some of the implications of that being out of whack. Other treatment modalities, I'll breeze through this. Ozone therapy, some may be familiar with that. We use a lot of that in the office. IV therapy, a lot of IV vitamin C in conjunction to neutralize and to negate some of the chemical toxins that a patient can be exposed to. So we'll sometimes administer or facilitate that. Serum compatibility tests, we're doing less of these now because we've honed down our materials to just a very select group that work well, that look well, but are very safe. But if a patient's very hyperreactive or we're concerned, we can test your serum. And this isn't just available to us. Dentists can have this, and there's other biological dentists that do. That you can test basically an allergy test for the materials you're going to put in your mouth. If you're going to make it a permanent part of your body for the next 2 or 3 decades, we want to make darn sure that it's compatible. PRF therapy, we do some therapy with platelets where we can optimize and enhance some of the healing at some of these extraction sites and surgical sites. We'll do a blood draw and actually place these healing aggregates back into those places, and we're seeing some real promise there. I mentioned the body work, trying to optimize lymphatic drainage with pre and post-op body work, some of the different therapies that can be done. Sleep medicine, that's a big topic. Patients that don't rest well, that aren't breathing well, that are apneic, that, and a lot of times that goes undiagnosed. We can address that in dentistry. Some of that's done outside of dentistry. In fact, a lot of it is, but it needs to be addressed, it needs to be looked at. The craniofacial development, that's another thing Weston Price talked a lot about, was how diet, in his book, Nutrition and Physical Degeneration, how diet affects our or growth, the development of the craniofacial bones, the maxillomandible. And he showed very eloquently in his studies that there's a lot more to it than just diet, but diet's huge. And what we're getting through our diet nutritively, and the fat-soluble vitamins that we're so dependent on in certain stages of development. If you get underdeveloped, bones in the head and neck, it's going to affect airway. And your body prioritizes airway more than it prioritizes anything else. You can only go minutes without air. And so it'll go to great lengths to optimize airway. Well, sometimes you see some unfortunate craniofacial development that kind of dabbles in the ortho issue. You see a lot of orthodontic problems. He saw that in a lot of his travels. In some of these populations that have had very little exposure to processed foods and what he called a Western diet back 100 years ago. And they had just very proportional faces. They had room for all their teeth. There was no need for orthodontics. Very just gorgeous teeth, no decay, lined up well. And these people they don't even know who a dentist is. And, but it just kind of proves how influential and how crucial that is, especially at a young age, in developing, in making sure that the nourishment is there, and subsequently the body, it knows what to do. It'll form in a way that's optimal. Advanced 3D imaging, phase contrast microscopy. We talked about the tooth meridian chart. A few topics I haven't talked about, I don't have a slide on. Fluoride is an issue. A lot have heard about that. I am of the opinion that we get enough of it through the water. I think too much of it is a bad thing, and that's not just my opinion. There's been plenty of studies and opinions that would agree with that. Studies that show that, it can affect a lot of things: thyroid, pineal function, IQ levels. There was a Harvard study that showed that being a concern between the neural development of children that had been exposed and had abstained from exposure to fluoride. That comes out of an old way of thinking again. A little bit of fluoride in the enamel, I don't think anybody could argue is a good thing. It can optimize and make that enamel of the teeth more resistant to decay. But too much of it can be a really, really bad thing in the mouth and systemically. So I am one that will recommend that we stay away from it. I think there's too many, in my opinion, too many risks that don't negate the benefits. And there's so much more to having good, healthy teeth and mouth than just putting a chemical in there and counting on it to do the work. Implants, most are familiar with that. We don't do a lot of them. We have to really be cautious if we're talking about dental implants to make sure that that person is in a state where if they want to go in that direction, they can handle that, because that is a foreign object. Most do very well. I see a lot of them come through in patients that have had them done, but you just have to be sure, because once they're done, they're in, and they're hard to undo. So you just have to make sure that that person, if they want to go in that direction, can tolerate that object. They're doing a lot with ceramic implants now. That's showing some promise. I think you had mentioned the nitrous, the idea about nitrous oxide. Most love the stuff. They've had it. It's great. It helps us to, it really helps patients in times when they have to have some work done. The concern is in patients that don't methylate well, if there's some genetic susceptibility to methylation, or if there's other outside forces that are hindering that person's ability to methylate and to deal with some of these outside influences. There were some studies done that I did read that were very concerning about nitrous with that. Now, it was done in a capacity outside of a dental office. The ones that I read, there's a lot more involved, but it at least put that on my radar to talk about and to be somewhat, I won't say concerned about, but it needs to be addressed. And that needs to be a decision that's made between the person or maybe the child and the dentist, and with plenty of information about it. So it at least needs to be looked at, and there needs to be a pause before we move forward with that. And that goes for the sedation drugs too. We do a lot of IV sedation. Most of the medicines that we use are very inert, but again, you got to pay attention to the person that's going into, and if they can handle that, and if they've had past histories with problems, or if there's risk involved with that, it needs to be discussed. Lyme's disease is something that a lot are looking at now. There's a lot of correlation between that and some of the microbes that are involved in dental processes, a lot of synergistic, negative synergistic co-infectious bacteria. So we pay a lot of attention to that, especially when working with physicians whose patients may be in the midst of or being treated with Lyme's. Another interesting thing, this may be a bit applicable. We had a lecture from a guy that talks, Dr. Curtola, is a dentist researcher at NYU, and he talked a lot about the oral microbiome. He's kind of the pioneer in that. In fact, he's got a book out. He's great. His concern was xylitol. You see a lot of xylitol in these as a natural alternative to sweet or aspartame sugar. And the concern was, we know xylitol has some antimicrobial effects. My understanding is it really breaks up the biofilm. It may not kill the bacteria directly, but it allows them not to form these communities, and subsequently they can't survive. Anybody that's put too much xylitol or stevia, or not stevia, I'm sorry, that's a different thing, xylitol in their coffee knows real quick that it can lead to GI disturbance. And what's happening is it's interfering with those bacteria's ability to form communities. And so it has antimicrobial effects. That's a concern if you're trying to optimize the biome. You want good bacteria to form, and you want a balanced ecology. And he cautioned patients about using xylitol. I mean, a little bit here and there. I mean, I guess we have to keep it in perspective, but it is something to consider. Even it's something as mundane as picking out a toothpaste. We want to use other toothpaste. A lot of the over-the-counter stuff has triclosan in it, antibiotic. That's just unnecessary. You don't want to kill bacteria. You want to optimize the mouth so that the bacteria that you do want growing in there and helping you are in there. Plus the source of a lot of the xylitol. I think he said greater than 90% of xylitol that's off the shelves made from corn cobs, leftover corn cobs. And unfortunately, corn is one of the most genetically modified, foods that we do. And so there's the ethical and the health concerns about the GMOs, depending on where people are on that. And that's unfortunately is a controversial topic. But that can be a big source that some don't even consider. It's right under their nose. It's in their health toothpaste and a lot of these health products. And so that's interesting too, something to consider. Protective protocol. Again, this is just some of the steps that I think need to be taken if some of these materials are going to be removed. Proper isolation, proper ventilation. We use nasal hoods. You'll see us wearing these respirators because if we have to take a lot of mercury out, there's been studies done in offices to show that, I mean, you can get way beyond a safe limit of elemental mercury by taking removing these fillings, especially improperly. So everybody needs to be protected, us and the patient included. And then there's some other things. We'll do some, some IBC and some different things along with it. So there's some very well-established protocols that we did not make up. There's been some people that have been at this for a long time. We've added to and adjusted these protocols, but for the most part, these are some pretty well-established safety protocols. If you are going to do this type of dentistry, I believe it needs to be done safely, and if anything, over the top safely. Some helpful resources. I just put these in real quick. There's so many more. IOMT is a group we study with. A patient can get on there. There's scientific reviews. They have position papers. It's a great resource if anybody has questions about some of the stuff that I talked about. And some of these other ones too. These are great. There's a lot more than that. So that really is it. I'm a big quote guy. So I like this one from John Muir. Granted, he wasn't a dentist. He was a naturalist. Says, when we try to pick anything else, anything out by itself in nature, we find out that it's hitched to everything else. So that's kind of defines the holistic view. If we start compartmentalizing and just trying to treat these parts without at least acknowledging that they're attached or hitched to the whole, I'm not so sure is the best approach. The approach would be the whole person sitting there, whether you're looking at the mouth or the gut or some of these DNA genetic issues. you've got to address the whole, not the part. And then this is just a good quote that talks a lot about beyond the physical, just the emotional healing that can take place oftentimes. I was asked to kind of come up with 3 kind of take-home messages. I don't know, these may not be go home today and use them. I would definitely recommend in the dental realm is to be very cautious and calculated when you are making a decision for you or a family member or kiddo as to what's being used, and do your research and find somebody. This is another one, is find somebody, whether it be a dentist or a physician even, that is going to acknowledge your concerns, going to listen to you, and help facilitate you reaching your goals for your health. You know, as a provider, we should be a tailwind for a patient, not a headwind. And so everybody's got their philosophies. Practitioners can choose how they choose to practice, but you've got to have a good team, if you will. Everybody's got to be rowing in the same direction. And so find somebody that will acknowledge and respect that. I don't have the quote, but it goes something along the lines of, one of the best physicians that ever existed is the one that's inside of you. We do our research, you use your discernment, and oftentimes you're going to make a pretty good decision. And then I know this organization, that the CC4C is great. It provides families, my understanding, that have children that may have issues or conditions that they're not sure about, or they may be undiagnosed or untreatable. In general, I think it's good just to always remember, never lose hope, that there'll be answers to questions that may not be here now, that there'll be certainty that takes the place of uncertainty one day. I know firsthand, having, again, gone through a personal experience with secondhand, not myself, but a sister, that there's a lot of purpose and there's a lot of good that can come out of our hardships. And so I can speak firsthand about that. But one thing you can't do is lose hope. So surround yourself with people that give you hope, and always have hope that we may not know today what we may know tomorrow. And so that's really it. That's all I have.
Thank you. That was beautiful.
Yeah. And I would also say too, I don't have my email on here. There's our website. It's good. It's not quite as informative as I'd like, but it's a good site for some basic information. We do have our email on there, and I would be more than happy if, I know dentistry in general is you get emotions tied in, you get past experiences. It can be something that a lot are hesitant about. Very informal questions. Shoot me an email. I don't mind answering questions. It doesn't have to be in a clinical setting. I mean, I can only answer so much. But by all means, if you or if anybody that is listening to this has any questions, I'd be happy to field or answer any. There are biological dentists out there, some that really do believe in it and practice this way. And there's tons of resources. You got to be a little careful online, but most people can tell the difference between what's good information and what isn't. And so you always want to encourage patients to read what they can. We've got great books and resources here that we can point people in that direction, as well as plenty of other places. And so I would be more than happy to answer any questions, whether it be now or if people are watching this later. They can shoot me an email or give us a call. So
thank you. I've got a question for you.
Sure.
What are your thoughts about, I know you briefly mentioned it, but having wisdom teeth removed on kids?
Okay.
Just to have them removed, because I know some, like my kids' dentist they said my son probably needs his removed, and then they just wanted to remove my daughter's just because that's something to do, I guess.
Well, that's a good question, because that's kind of up for debate, pretty relevant now. Used to, in the interventionalist mode, take them out, right? You look at histories, you look at patterns, and going back, as long as there's been oral surgeons and dentists that have the ability to take them out, they would just recommend. And some of that might have been for good reason. They can be an issue, but actually just recently, even the Academy of Oral Maxillofacial Surgeons, which they're the ones that do the majority, we do a fair amount of wisdom tooth removal, the ones that we can handle, and we'll refer to an oral surgeon as well. But they actually, my understanding, their position now is to be a little more reserved in saying that if there's not a direct reason, if it's just because they might be a problem and you don't see a problem, or it's too early to see a problem, I believe their position is even don't do it, because there's implications to surgery, short-term and long-term. And so now if it looks like there's going to be an issue, not just crowding, but if there's some, potential damage that'll occur, if it's going to begin to compromise adjacent teeth, there are times when they do need to come out. And I didn't really go over our protocol on that, but the best thing you can do post extraction, especially wisdom tooth, is as atraumatic of removal as possible, because that tissue is going to heal better. Rest and minimal movement and minimal activity for a couple of days post. You want to avoid dry sockets and the things, all the terrible stories that you hear about wisdom teeth. We tend to do a lot of, you want to remove all the tissue, whether there's infection or cystic tissue, the ligament. We can do some of the blood, the platelet work to optimize the healing, to minimize the chance of some of these issues down the road, like capitations forming. So I think that's an answer to your question. I always will tell patients, first of all, again, you go over it with them. Here are the risks, here are the benefits, and what do you want to do? Some patients are willing, or parents are willing to, I don't say take a risk, but say, well, okay, I'm going to weigh that out, and this is something that I don't think is necessary. And I've got a lot of patients that are in their 70s and 80s still have wisdom teeth. So I don't think the blanket statement that if you have them, they need to come out is the case. Sometimes there's orthodontic concerns, and that's true to some degree. One tooth probably, I don't believe, is responsible for pushing a whole row of teeth in front of it. It can lead to crowding and things down the road, but there's a lot more at play there than just the wisdom tooth pushing on that. I'd be more concerned about the damage to adjacent teeth, or if it's in a position where you can't clean it and it can be susceptible to problems. So that's my take on it personally.
What if they're in there sideways, like they're not angled down where they would come out, they're completely like sideways? Is that a concern?
Well, possibly. Again, it depends on where they're at. If I had x-rays, I could show you. Sometimes they may be in at some of the weirdest angles. They'll be upside down sometimes, or 90 degrees. But the big thing is there any communication from that kind of cystic around that tooth into the mouth? If there's a pocket that leads down there and it turns into an unsustainable, uncleanable pocket, it probably needs to come out. If they're completely encased in bone and there's no cystic problems, you'd have to make sure there's nothing going on. Sometimes you can get some benign cystic growth around them. The proximity to the nerve that runs beneath the lower, there's a nerve trunk that runs beneath wisdom teeth, all the teeth on the lower, and they're the most common to come in impacted. And if there's a risk of nerve damage, and you balance that out with these probably are never going to be a problem, then you leave them alone. But that's a very individual thing. But that's my advice I typically will give. We'll recommend it sometimes, but sometimes patients get 4 decades down the road, and if teeth are lost in front, sometimes it's nice to have wisdom teeth. You can use them to tie onto or use them to use. And so same thing with ortho extractions. They're doing less and less of that now. Fortunately, that you can do some functional orthodontics where they're expanding palates and making room for teeth rather than removing teeth and using that space. So more now are getting away from removal, and there still are times when you have to do premolar removal, even if you don't want to. But most of the time now, you probably can avoid that. And obviously, leaving as many teeth in there as you can is a good idea. So
great. Does anyone else have any questions? There's people, some are on mute, so I'll give them a second to unmute.
Yeah. I'm sure if not, they'll crop up tonight.
Probably.
lay awake
Well,
thinking about dentistry.
I've been through a gamut of what you just went through, that whole presentation, because I had a car wreck when I was 16 and knocked a lot of my teeth out, and I've had implants, and I've had a lot of had root canals that I've had removed, and that's caused, you know, cavitations and well, it just pretty much everything you covered. So I've been through it all.
You're familiar firsthand.
I am.
Well, and most of the time, I mean, the best thing obviously is to avoid, I mean, yours is a situation, and there's situations that unfortunately are unavoidable, but I would say this, and I could back this up with science if you wanted me to. Most root canals are avoidable, meaning if you can catch a problem early enough, most of the times it's a known problem or an overlooked problem that precipitates into a bigger problem, cracked tooth that's not symptomatic, not bothersome, and 5 years later it either wasn't seen or it wasn't treated, or the patient wasn't told to have it done, or they were told and they didn't, or, you know, old fillings that are beginning to break down and decay beneath. If you can be very proactive in preventing something from progressing that far, you can keep from needing a majority of the root canals that are done. Now you get into trauma and some of the things you're talking about, but it's still a choice, and so you still have to weigh it out and decide. Again, we don't do them. If a patient chooses to have one done, we'll work with a specialist to have it done well, but we just want them to know that they need to know both sides of it before they make that decision. And then in what you said, having things addressed subsequently, removed or addressed or whatever it is that you had done, or some may, it just needs to be done in the context of using the protocols and the safety, and just making sure that it's done to where, you know, to where it's the safest and long-term, you get the greatest benefit of that.
Right.
A lot of these protocols aren't taught, and we're not taught in school, and a majority aren't ever. I mean, I didn't know until I started studying that we have to take these precautions. Some may disagree. You know, again, you're going to get a variety of opinions, but I feel pretty strongly about it. And then if it is going to be addressed, patients go to a lot of trouble sometimes, and a lot of effort to address some of these things. So you just need to make sure that it's done properly and with their best interest in mind, and take care that, you know, the old adage, you want to leave somebody better than you found them.
Right.
So yeah, it sounds like you've had a pretty good ride with yours. I hope that it all turned out well for you.
Yeah, it's still going on a little bit, but yeah, you know, I'll probably come see you and probably bring my kids in for a second opinion too.
Well, that's great. We love to. Again, you can't have too much knowledge.
Right, exactly.
You know, gather as much as you can, and then, like I said, weigh it out. But we'd be happy to do, and it's always nice to have. And I would imagine a lot of the people that will listen to this, if you're in the realm of just unsure and undiagnosed, or, you know, if there's things that a lot don't know about, I don't think getting several opinions is a bad idea. I mean, you want that. You want to gather as much info and get as much on your radar up in the air as you can, and then go from there. So yeah, so that's something that could be done.
Well, thank you for your wonderful presentation. And do you mind if I give out your email address whenever I send out the recording information?
No, do you want me to give that to you now, or I'll email it to you, or?
I think we emailed back and forth. Is that the same one you want me to use, or do you want me to use a different one?
I'll probably use my office one. I mean, it's my personal one. I use it. I've got 3 or 4, and each one kind of has its purpose.